All right, we come to our main program, and it's an exciting one, and it's a very important one. So I want to welcome David Ross to the screen, our own fellow member. Dr. David Ross, of course, is president and CEO of the Task Force for Global Health, and you've been in that post officially since 2016, but you've been at the global at the task force for over 20 years, and it's certainly in global health. In breaking down barriers, getting information, sharing information, and making the world a better place. So, David, thank you for all your work through the years, and thank you for hosting our panel discussion today.
Well, thanks, Ken, and thanks for having us. I'm really, really pleased that you invited us to come on and talk about the domestic and international COVID situation and response. I'm really fortunate to be joined today by three colleagues who each plays an important role in the response. I'm going to make a few remarks summarizing, as I see it, where we stand with COVID globally and domestically. And then I'll turn it over to Dr. Joe Breese, who will then turn it over to Dr. Bob Chen, who will then turn it over to Ms. Karen Ernst. Just so you all know, these are real experts. Joe is the Associate Director for Global Affairs at CDC's Influenza Division, has played a major role in CDC's COVID response, and plays a role at the Task Force for Global Health as our Director of Respiratory Viral Infection Programs, which includes influenza and now COVID. Dr. Bob Chen serves as the Scientific Director for the Brighton Collaboration, and that's a global collaborative of vaccine safety researchers. And Bob is, like Joe, a former CDC person. He retired from CDC, but not before he had helped set up the modern infrastructure we have today for monitoring vaccine safety across the globe, which is why Bob is in the role he is with the Brighton Collaboration. And then Karen Ernst is on our panel today, and Karen runs the Voices for Vaccine program, which is a parent-led organization that advocates for vaccines and teaches people how to instill confidence in their peers such that people become adequately vaccinated. So despite being a very busy parent, Karen has found both the passion and the energy to be a dynamic force in support of vaccine education and action. So we're really fortunate to have each of them with us today. So as I begin, let me start with a basic proposition, and that is that when it comes to the pandemic, I think I would argue that we're not safe from this virus until we're all safe. This is a global problem. It's not just an Atlanta problem or a Georgia problem or a US problem. These viruses mutate over time, and by doing so, eventually they may mutate beyond the protection that's provided by your immunization. Therefore, the sooner we vaccinate the world, the sooner we're all going to be protected against adverse effects of future variants. So the Task Force for Global Health strategy is essentially to help get the world vaccinated, and in doing so, to build sustainable national vaccination programs for diseases like influenza and COVID. It also means that we have to play a role in helping with the supply chain, assuring delivery to the end of the road, which we do a lot of. And I talked a bit about the last time I spoke to this Rotary audience. So let's go to slide 1. So just briefly to remind you all, the task force is a global nonprofit. We've been founded here in Atlanta for nearly 40 years, working with partners in more than 150 countries to advance health equity so that all people can achieve their full potential. And the countries shaded in blue are where we work. So you can see we are mostly everywhere. Next slide. To put my remarks in context, let me give you a quick overview of the kinds of issues we work on and what we do. So we tap our internal scientific and public health expertise and collaboratively work very closely with partners such as WHO, the CDC, ministries of health, and civil society groups, the private sector, and other global health and development organizations. And we work in 3 areas. We work to eliminate diseases, including those like polio that Rotary is very involved in, and probably should be a future discussion. We ensure access to safe vaccines by both informing the development of vaccines and in the development of vaccines and delivery of vaccines, and then strengthening health systems. So we work to protect populations and advance global health security. And this includes everything from training epidemiologists, or what you may know as disease detectives, to strengthening supply chain and delivering the data and information needed to monitor populations for potential threats to health. Next slide. So this slide, hope you can all see it, but basically the top curve is the epi-outbreak curve that summarizes, in this case, the daily cases. Since the beginning of the outbreak in December 2019, the U.S. has seen roughly 33.4 million cases, and we are approaching 600,000 deaths to date. This epi curve shows the waves that we've been through. We've all become very familiar with the whole notion of another wave, and tragically, that is what's happened. And this is a real challenge, as every jurisdiction has struggled to try to deal with taking actions that can contain the spread of the virus leading up to the vaccination program, and what it can do to actually encourage vaccinations while trying to avoid another wave. The small curves below just show the daily COVID tests, hospitalization, and deaths. And of course, each of these curves shows the same general trend that things seem to be getting better here in the US. Next slide. On this graph, really what I want you to focus on is that we and our friends, we need to be aware that we really are in a race to vaccinate the country and the world before the so-called Delta variant, which is a very highly contagious corona variant that was first seen in India, is now overrunning Great Britain, before it becomes predominant variant in the state of Georgia. The strain has been detected in Georgia and therefore should raise alarm in our state, where vaccination rates are lower than other states. If you notice the Northeast and the far West, the vaccination rates in the darker shades are much higher. So the coverage rates, for example, in the Northeast, where the darkest shade of green is, are like 48% of the people vaccinated, ranging down to a low in the lighter shades of 36% coverage. So we have a long way to go. So very simply stated, we are in a race to vaccinate. And this also leads me to, I just have to throw out a kudo to my colleague, Lee Zach, president of Agnes Scott College, for stepping up and having Agnes Scott College, for example, be a vaccination site and work closely with the administration's vaccination program. We should be proud of all of our member organizations that are doing that. Next slide. Now, here we take a look at the globe. This map of the globe displays the average daily reported cases per 100,000 people. So we see major hotspots in the darkest red. These countries reflect more than 68 new cases per 100,000 population daily. The countries in the lighter shades reflect the average of less than 4 cases reported daily. So over the past year and a half, this equates to about 175 million cases and almost 4 million deaths. We should also, though, be honest with ourselves. These data, particularly in lower and middle income countries, are probably crude estimates of reality. They may be having much higher rates than reported, because their abilities to report are often not as great as, say, we have in the US. Next slide. So in the US, we We know that we have significant socioeconomic and racial disparities that have highlighted equity issues at the U.S. national level. The global context underscores further disparities, very similar. A quick look at the percentage of countries' populations that are covered show that U.S. and U.K., we've got vaccination rates now at 43%. The European Union countries are lower, around 22%. India is showing vaccination at about 3.5%, and most other countries are under 2%. This tells us that we've got not only a big job ahead to vaccinate the world population, but it also says that there is an equity issue here, and we've got to do a lot more to get vaccine to these countries and to get people vaccinated. Next slide. So in my closing, and I'll turn this over to Dr. Breese, if COVID has really taught us nothing else, it's that a risk anywhere presents a risk everywhere. To reach this widespread vaccination coverage, we're going to have to address supply constraints, as we've seen happen with challenges getting vaccine that was in production in India going again and out to other countries. We've got to address the infrastructure support needed in low resource countries. Dr. Breese will talk about this. And we've got to look also on the demand side of this, and that is we address safety questions, understand how vaccine safety is being monitored, and how issues of vaccine confidence are challenging. So Dr. Chen and Karen Ernst will address these issues. So with that, let me turn this over to Dr. Breese.
Yeah, thanks, Dave, and thanks for having me, everybody. It's really a pleasure to be here. If I can have the first slide, we're going to start with history as well, and taking the context that Dr. Ross just gave you. Let me talk a little bit about vaccines and how we're using them, and the component of the Task Force Global Health's program to make sure that inequity, that vaccines that Dave mentioned, that vaccines are actually available everywhere and available as quickly as we can everywhere. But let's start here. Pandemics have occurred forever, probably in the human race, and 5 in the last 100 years or so. But only since about 1957 pandemic, of the flu pandemic, the Asian flu pandemic, have we used vaccines in response to pandemic threats. And the problem with that has been historically that vaccines take a while to be developed once a pandemic starts. And they have often been available later in a pandemic, and therefore had a fairly modest effect on the course of the pandemic. And so a lot has been done in the last 20 years by national governments and others to think about how we can make vaccines faster, how we can make more of them, and how we can make them more effective. So next slide, please. So as we get into the COVID thing, all that work over the last several decades has really borne fruit, and it really is an amazing success story in terms of making vaccines. There's been lots of vaccines developed, new approaches, new technologies. Overall, there are 312 different vaccines either in development or licensed for COVID, and amazingly fast development of a lot of things happening at the same time. The second thing is the vaccines that we have are highly effective, 60 to 95% effective. And more than that, they're more effective in preventing the most severe outcomes, including death. And finally, we can make them in large amounts, that we expect 21 billion doses of vaccine to be available by the end of the year for global distribution. The problem is with all this is that we not only have to make the vaccines, we have to use them. We have to make sure they get from the tarmac at a national airport into the arms in the most remote village in a country. And that's where the task force comes in. Next slide, please. So one of our roles is to help countries in low and middle income status use the vaccines and have access to vaccines quickly and effectively. We're building this COVID program on a previous program we started a few years back called Pivi, or the Partnership for Influenza Vaccine Introduction. Pivi is a public-private partnership that's meant to create sustainable seasonal influenza vaccine programs in the poorest countries, and to use that to build the infrastructure to respond quickly to epidemics or any pandemics for which vaccines need to be used. Next slide, please. And so building on the sort of the expertise, the experience, and the lessons learned from Pivi, we developed a new program quickly during the pandemic called the COVID. And COVID is the same sort of thing. The idea is it's a group of technical experts, a public-private partnership between CDC and the task force and a lot of other folks to ensure that low and middle-income countries are ready and able to deploy and evaluate COVID-19 vaccines when they become available. Next slide, please. And this is going to be hard to see, and I apologize, but it really describes the whole program in one snapshot, so bear with me. This is a global map, and the countries in green, dark green, and light green are the countries where COVID with CDC and the task force are working or may work. We have 53 countries now with the addition of Ukraine that we're working in now. We're working to help countries plan, to help countries evaluate and learn lessons and refine their vaccine approaches by the provision of all sorts of different technical support and some funding. The dark green countries are the 53 countries we're working on. The light green countries are countries that we may work in based on some of the recent information about US government vaccine donations to some of these countries. So we expect really to expand our reach and really have a large global footprint. And there's three parts to the program sort of conceptually. One is that we help countries plan and implement the vaccine, all the things they need to know who to vaccinate, where to vaccinate, how to get the vaccine out, and actually to do it. The second thing is this blue box, monitoring and evaluation, because COVID vaccines roll out incrementally, roll out over time, the same way they did in the US, where you vaccinate health workers and maybe older adults and maybe adults with underlying illnesses, et cetera. Same thing's happening everywhere. And so it presents a great opportunity to learn lessons quickly and to refine those programs to make them better and more effective and more timely over time. And third, and really importantly, because of this massive footprint that we have the ability to cobble together all the learnings from all these places and improve and sustain the vaccines for global use. And I want to mention sustain, and I'll stop after that. One of the real opportunities that we have here with COVID is not only that we have a lot of vaccines that are very effective, available very quickly, but we have the ability to take the experiences with countries, especially low-income countries that have never really used vaccines in a national way in adult populations, and use that to build and sustain that capacity for future use, every year use, maybe with hepatitis or influenza vaccines, but certainly use during the response to epidemics. So we have a really big opportunity to use a lot of money, a lot of vaccines, a lot of interest, a lot of smart people in the next year or two in rolling out these vaccines to build sustainable systems that we can use the next time we have a pandemic. And I'll turn it over to Bob.
If we could move to my first slide, and it's, again, also my pleasure to introduce our project within the task force called the Brighton Collaboration. And our goal is to build trust in the safety of vaccines via rigorous science. We've been around since 2000, and in pharmaceutical products, we're going to hear their terms kind of safety and efficacy. And in my little introduction, I wanted to kind of give a bit of an overview on kind of the safety problem, if you will, that applies not only to vaccines, but all pharmaceutical products, and kind of how to think about it. And when questions arise, why is it that sometimes it takes a while to kind of solve this issue? So the problem is that in the first place, unlike efficacy, safety generally cannot be measured directly. And that we have to kind of infer safety from the relative absence of multiple possible adverse events following immunizations that are actually studied, and then the size of the population that actually received the vaccine so far. So we kind of, from that absence of problems, then we infer whether something is relatively safe or not. But yet, in the beginning, we cannot offer that absolute guarantee, because the clinical trials are kind of limited in population of people who are studied. And then the other problem is that since we're looking at multiple different possible adverse events, And if they're rare, they can be easily missed. And if you didn't have a standardized way of classifying them, what we call case definitions, then they're going to be easily missed. So part of the problem with safety is that the nature of the beast, if you will, is more challenging compared to the efficacy side of any clinical trial or of any pharmaceutical product. And so our mission at Brighton have been to develop international accepted standards for monitoring vaccine safety throughout the vaccine life cycle to enable us to get to these safety data sooner. We relied on volunteers, by and large, from different domains, and through 20 years or so, we've now developed the case definition for over 60 adverse events at this point, and we. The initial home was based in Basel, Switzerland, and about a year and a half ago, we relocated it to be part of the task force. Next slide. Okay, so then why does the public kind of take vaccine safety so close to heart? Well, I think in general, it's safe to say that a higher standard of safety is expected for vaccines compared to other pharmaceutical products. This obviously comes from the first do no harm principle in medicine, but that the decisions involved affect kind of the general whole public health, whole population, more than kind of clinical medicine, which tends to deal with one patient at a time. And then vaccines are generally healthy compared to people who are already ill, let's say with cancer, for example, and they're willing to tolerate much higher rates of side effects compared to healthy persons, especially if it's your healthy baby. And then vaccinations are universally recommended or mandated in most countries, and all of that kind of in sum add to a higher standard of safety. Now, this lower risk tolerance means that we have to study and search for more rare reactions compared to other pharmaceutical products. And so in vaccine domain, reactions as rare as 1 in 100,000 or even more rare, kind of 1 in a million, will impact policy decisions, whereas in drug domain, again, as I mentioned, that if you have cancer and your chemotherapy results in nausea, vomiting, your hair falling out in 100% of people, that is still totally acceptable. And then with most routine medications, side effect rates in kind of 1 in 1,000 are common and well accepted. The problem, of course, is that study of rare events are going to be more costly, more difficult, and less likely to be definitive. And so in this day of kind of immediate gratification expected from mass media, we unfortunately are caught by the numbers. We simply aren't able to, mathematically to come up with such certainty quite so quickly. Next slide. And then the other problem is that there is kind of a built-in cross-communication between the healthcare domain and the general public. Here's a slide showing the success of immunization programs in reducing several target pathogens from diphtheria down to tetanus, from pre-vaccine era of the number of cases in the tens and hundreds of thousands of cases to most recent year, 2019, with this very small number of cases shown there and close to 99 or 100% reduction. And this is the immediate way that anybody working in healthcare or public health tend to view this problem. And yet, The other challenge is that in terms of vaccine adverse events, you've gone from 0 cases in the pre-vaccine era to 2019, kind of 11,000 reports of adverse events after vaccines against these same pathogens. And so to the average person walking on the street, they tend to view this issue in a vertical perspective, that they are just as likely potentially to have an adverse event compared to running across a case of pertussis or measles or something. And so this kind of built-in cross-communication frequently is a challenge when we try to communicate and deal with the public, because the healthcare workers kind of come in with a kind of a different mindset, if you will. Last slide. So I kind of the issue that we're running into with COVID-19 vaccine acceptance is somewhat similar to the same issue that we've run into with other vaccines and the public concerns about those adverse events. And I've kind of summarized it here in terms of this slide. We're on the x-axis of showing the maturity of the immunization program, on the y-axis incidence of 3 different things, kind of wild disease in blue, the vaccine coverage in red dotted line, and adverse events in yellow dotted line. And we have kind of 5 stages in the immunization program. Number 1 is pre-vaccine. So before we had a COVID-19 vaccine, or before we have a HIV/AIDS vaccine, all you have is a high rate of disease. Stage 2, once you have a safe and effective vaccine that's licensed with increasing coverage, the disease rate comes down, but there's an increasing number of adverse events, both kind of true reactions due to the vaccine and coincidental problems that are blamed on the vaccine. And it kind of sustained high levels. The 2 lines, disease and adverse event, approximate each other, and it's easier then for a media scare to result in kind of loss of confidence, drop in coverage, and for the outbreak to return. Now, hopefully, then you're able to resume confidence at some point, and then for certain pathogens like smallpox, like polio, you potentially could actually eradicate the disease, stop the vaccination, and also eradicate the adverse event. Now, the challenge is that in the less innocent era of kind of bioterrorism, the idea of stopping vaccination becomes kind of less attractive, because it would potentially create a opening for bioterrorists to take advantage of that immunity vacuum. So by and large, most programs in the world are going to be back before stage 3 with high coverage, relatively low disease rate, fairly prominent adverse event rates, awaiting the next kind of loss of confidence from a media scare. And so this is where we've been trying to intervene to better understand these adverse events and try to prevent them from coming and avoid this unstable situation. So this is a bit of the overview, if you will, not only for COVID-19, but for other immunization programs, be it polio, be it diphtheria, etc. So with that, then I'm going to turn it over to Karen to introduce her work.
Thank you so much, Bob. That was a really interesting presentation. And I'm so happy to be here talking to you at Rotary about how to talk to your friends and family members who might be unsure about vaccines. Next slide. So there are a couple of things that I want to have you consider before embarking on a conversation with somebody about vaccines, especially someone who's unsure about vaccines. And that would be primarily that the way that we think about how we make health choices is not actually the way that we make health choices. We think that we are presented with evidence and we look at the facts and we make rational choices, but none of us does that. The truth of the matter is that we make our health choices based on values, our own personal value system, emotions, how easy it is to get a vaccine, and what feels risky or less risky to us. And that's true for all of us. especially if we think about if we got a COVID vaccine, I'm guessing that a lot of people who got COVID vaccines got them because of particular personal values that they carry. We're seeing certain partisan divides when people are choosing to get vaccinated. We're seeing some gender divides. We're seeing some people who have been subjected to health inequities who are a lot more cautious about getting vaccinated. And so those values are really very important. And as is our perception of risk. As Dr. Chen pointed out, the perception of risk has ups and downs relative to disease. And so at the beginning of vaccinating, when we all were really excited for the pandemic to be done, the people were rushing out to get their vaccine. And now we're seeing it sort of tapering off a little bit. And now we have that hard work of doing the one arm at a time convincing to get our vaccines. The second consideration I want you to keep in mind is that if you are like me, and that's someone who's not a doctor and doesn't work in a clinic, you don't actually carry vaccines around in your back pocket. I mean, there might be some of you who do somewhere in the world, but I am not a person who carries vaccines around my back pocket. And so when I'm having a conversation with somebody who has uncertainties or is unsure, my conversations aren't immediate. I don't have to convince them right this second to get a vaccine in their arms. All I have to do is move them closer to that. And then, okay, next slide, sorry. There are also pitfalls because of these considerations. And that is that when we approach someone or someone approaches us with uncertainties or questions or outright refusal about vaccines, it's easy for the conversation to become a debate. So they share with you their facts, you share with them your facts, and their facts might have you having certain emotions. If they say to you, I see that people are becoming magnetic after getting vaccinated, you might have an automatic and very real reaction about that being ridiculous or dumb. And that person might think that you are making fun of them or belittling them. And so that's really important that we don't want to do that. It's also really important that we emphasize that people are responsible for making their own health choices. That of course it's that person's choice to refuse or accept a vaccine. And that you respect that you're not trying to personally force them to do it. And the biggest one is that we will lose patience with them. Remember, you don't have a vaccine in your back pocket. You've got all the time in the world. Just take your time with them and know that it could be a very long conversation. So how does that work then? How does that conversation actually take place? Next slide. We've got a little recipe for success that I want to share with you. And that is, we take somebody who's a trusted messenger. If someone comes to you with uncertainties about vaccines, they probably trust you. If it's someone you care about, you know them, they know that you care about them, then you're a trusted messenger. So see yourself as a trusted messenger. Set some reasonable goals for what you're going to accomplish in this conversation. If your goal is maybe just to convince them that they won't be magnetic or that you're not magnetic, that certainly is a reasonable goal to set. That's something that you feel like you can accomplish in the time and space and with the resources you personally have. I think that setting a goal for someone who is refusing to vaccinate completely of, I'm going to make this person make an appointment by the time I'm done talking to them, is probably unreasonable. So we want to put it somewhere in there where you can get them to accept something that you see as true about the vaccine. The next really important thing is, actually these two next things are bundled together. You have to have empathy for the person and you have to listen carefully. So when we're having empathy, that's really one of those deals where we can understand why people are concerned. Yes, a year and a half ago, we hadn't even heard of COVID and now we're vaccinating against it. Yes, that does feel fast to me. How is that science working completely and thoroughly in that short amount of time? I get that. I understand how that feels fast. So accepting that their reasons are rational and reasonable to them and probably logical, even if they are drawing incorrect conclusions based on what they know, is a way to express empathy and to really listen what's really beneath the surface of their questions. Dig into that, ask them follow-up questions. Don't think about how you're going to prove them wrong. Think about how you're going to ask them for more information and how you can learn more from them. And then the last really very important and very difficult tip is to build on what the other person already knows about vaccines. And so, you know, if they know, for example, that we hadn't heard of COVID a year and a half ago, and now we've got a vaccine, then we might follow up by asking, so what do you know about how the vaccines were developed? Like, where are we starting? So let's build on that. Oh, you know that about the clinical trials. Do you know how many people were in the clinical trials? And then if they say no, you can say, can we look it up and can I share with you how many people? And sort of build from what they know and expand that so that they feel in control and in power with the information that you're sharing with them. Next slide. The last thing I want to really emphasize to you is that you are a success. Just by engaging in a conversation with somebody who has uncertainties, you are being successful. That you don't have to, again, get them to make an appointment right on the spot. Although if you do, kudos. But what you are showing them is that you are a trustworthy and empathetic source of information or help or support that they need. And that if they have more questions, they can come back to you. And they probably will. And that's where having that patience really pays off, because you can keep having that conversation until they get to that place where you feel good about that. And so my last slide tells you that my name is Karen Ernst. And I also want to tell you that on Fridays, Voices for Vaccines publishes a newsletter that breaks down the latest myths about vaccines and tells you how to talk about those myths and where you can find some really good information to debunk them. I always say we take the bunk and we it. With that, I'm going to turn back to Dr. David Ross and let him kick off our Q&A.
Thanks, Karen. Thanks very much. And thanks to each of you for offering some words of experience and wisdom today to my Rotarian colleagues. Let me begin. We have a few questions from the audience, but one is kind of at the largest level. Joe, there's right now the question of vaccine passports. That's an evolving conversation. Wonder if you have anything you can say about that and whether that's going to be a meaningful, important development. But the other question I had is, like, if you had to guess, and if this is an unfair question, just say, hey, I'm sorry, I'm not going to answer it. But when do you think we would even get to, say, 20% vaccination coverage of all persons fully vaccinated in the low and middle income countries?
Yeah, asking a U.S. government person to guess is probably a dangerous thing. I would say first about that. WHO, the World Health Organization, has redoing their strategic plans and has coverage goals for this year and next year, and hopes that by the end of this year there'll be up to 30% of people worldwide vaccinated. Admittedly, though, the proportions in low-income countries especially might lag behind that. But the hope is that the world will rally around a goal of, by the end of next year, 2022, that about 60 to 70% of the world is vaccinated, including persons in all countries. And I think that's a goal that's achievable given the work that everybody's doing. The vaccine passports, I think, are interesting, and they're strangely controversial, I would say. Many countries are opening up, but they're opening up to people vaccinated because they want to minimize the chance they're introducing new virus into their countries through humans coming into their countries, as which they have the right to do. I think the vaccine passports will be useful. I think they'll be useful for a window of period of time that will be finite. So I think that as we open up this summer and in the fall, I think you'll hear a lot about them, and there'll be some countries asking for proof of vaccination. The technology to make a sort of an electronic vaccine passport that's available to everybody in the world is really, really complex. And I don't think that's likely to happen anytime soon.
Yeah.
But I do think that having proof of vaccination is going to be an important way to enter society in many, many countries in the world over the next 6 to 9 months.
Well, and I know, Bob Chen, we've only have you for a couple minutes, so I want to catch you before you have to leave. With the progress being made on safety trials for children, when do you think, if you had to guess, the U.S. government and the WHO will declare it's safe to begin vaccinating kids under 12?
Well, as you noted, those trials are underway, and let's see. So we're now at the middle of 2021. I would hope that by the end of calendar 2021, those kind of bridging studies to children should be available, and the regulators and the advisory committees will extend it down to those youngest age groups. So let's keep our fingers crossed. Within 6 months or so.
Yeah, I should also say, Karen, you answered my question about magnetism. I was going to ask you that, put you on the spot, but you actually answered it. So let me ask Joe a question. How do you think things will be different as we return to the offices, or to a public events, or events like weddings, or even going on a cruise ship? What's going to be the same? What's going to be different?
Yeah, I think that I think one thing that will be the same is it won't be magnetized by anything we do in terms of vaccines. I would say that in the short term, as things open up, I think the concern that we have is that we open up too quickly. And what I mean is, in a sense, that we forget what's worked so far. Certainly vaccines work, but masks, hand washing, staying away from people also work. And I think as we get back into these crowded spaces, I hope that folks have learned the best practices in reducing transmission of this virus, and continue them. And as you say, Dave, the new variants of concern, the new mutated strains that keep cropping up, are going to make this virus more and more challenging. It's such that vaccine is one tool, but the other tools that we know work are going to be incredibly important to keep going through this calendar year, at least I think.
Great. I'm not sure. I think that Bob's going to have to leave. Thanks very much, Bob, for joining the program. There is an audience question about infertility related to vaccines. Could either of you address that?
I'll take a stab at it. Infertility is often something that people become concerned about when it comes to vaccines in general. And I think that that's got a lot of weird conspiracy theory background to it. But with this vaccine, it's interesting because early on, there was a concern that the spike protein on the SARS-CoV-2 virus, which causes COVID-19, looked a lot like a protein that a human female would have to develop placenta when she is pregnant. And so there was a concern that if we use those spike proteins as a basis for vaccination, that a person's body would start attacking the placenta, or the protein that creates a placenta, and make that person unable to have a baby. Well, there's a few things that are wrong with that. And the first is that those spike proteins actually don't look a whole lot like the other protein. They look kind of similar, but the metaphor I've heard is that they're similar in the way that, if my phone number has a 4 in it and my neighbor's phone number has a 4 in it, if you call my phone number, you're not going to get my neighbor. And so if we vaccinate using the spike protein for COVID-19, we're not going to be causing a body to attack any placenta. but there are also other theories about how it might cause infertility in males as well, and I think those just sort of come sideways out from that. And it's one of those theories that I think, especially when we start vaccinating teenage girls, really comes out strong. And so, I mean, in short, people got pregnant during the trials. People have sustained pregnancies or gotten pregnant since being vaccinated since December, when we first started vaccinating people. And the American College of Obstetricians and Gynecologists feel that it is safe to vaccinate a pregnant person and that it doesn't cause fertility issues.
Good. Thank you very much. Ken?
Well, just fascinating discussion. Dave, thank you so much for organizing it. And of course, Joe and Karen, thank you. And Robert, who had to drop off. Very well done. So Joe, you outlined sustainable vaccination, the path to sustainable programs, I would say. And Karen, you got to the heart of messaging, which is so important. Obviously, between the two is that gap. And I'm just, maybe as our last question, how do we explore it? Because you've got science on one end, you got politics on the other. Never the two shall meet sometimes. And sometimes it's legitimate, privacy, personal freedoms, but a lot of times it's misinformation. So right. How do we build a sustainable program with messaging, in a scalable sense? I don't know if that's a fair question to ask, but that's what I'm left wondering.
Dave, do you want to start? Or?
Go ahead, Joe.
Well, I don't have an answer, but I think that's the heart of public health, isn't it? Public health is the nexus between political world and public policy and science and health. And I think as good public health stewards, I hope at CDC and the task force, I think we have not only a role in this, but I think we have a huge opportunity. Never has so much interest, money, support, new technologies be brought to bear against a disease as has been in the last year. And I think that we have a tremendous opportunity to do good with this. And not only good to the world in reducing disease, but as you say, Cannon, good in educating people and moving the population from a little more towards understanding the science involved, but also having confidence in the science involved and how public health brings it to bear. Yeah. So I think we have a real obligation to do this in the next year or two.
I think Karen also made this point, but it is in the era of social media, misinformation seems to spread like wildfire, while spreading actual, real scientific evidence is much harder. And yet, as Joe points out, public health sits at the interface of science and policy. And so it is a struggle for the public health enterprise nationally and globally to get the facts to people in a way that people can understand them. And I've had numerous conversations with people, and I sort of realized, like, oh, you don't really appreciate that the clinical trials actually did study and examine and track the frequency of events that would take place, and that there is evidence that would actually answer your question, but you're dismissing it because you either don't know that information or you're unwilling to look at it, or not willing or able to look at the facts as they actually are. And you may need some help. I just think the public health enterprise nationally is going to have to do a much better job of conveying factual information in ways that most people can actually consume it. Layer on that the challenge of individual assessment of risk. It's a conversation that we have to continually have, because your risk may be 1 in a million, but your perception of it might be that it's going to happen right to you right now. If that's your perception, that's how you act. So Karen has helped a lot with her Voices for Vaccine group to push this dialogue forward. We need more and more and more of that. And I really thank the Rotary colleagues here for hosting this program today, so we can at least start spreading the word for some more people.
Well, wonderful message there to end on. And actually we continue to have questions coming in, and one of them was, how can we make vaccine messaging simpler and clearer? And I think we started to touch the heart of that. So Karen, right in your wheelhouse there. But let me we'll call it a wrap there. I think it was a great discussion, timely discussion, and very well done. So thank the four of you for joining us today. Well done.
Thank you.